So the term early onset scoliosis is really just a designation of age. So children who are younger than the age of 10, when we make the diagnosis of scoliosis, we term that early onset. It doesn't necessarily tell us what kind of scoliosis it is. It can be congenital, you were born with it. It can be idiopathic, we don't know why you have this. It can be associated with a neuromuscular disease or a syndrome. But early onset sort of means that we just made that diagnosis of scoliosis before the age of 10. Well, like any type of scoliosis, the diagnosis is made with an X-ray. And the type of early onset scoliosis is dictated by the appearance of the X-ray plus the other conditions that the child may or may not have. The treatment of early onset scoliosis is one of the most complicated topics to cover, and it depends on so many factors. We factor in the age of the child, how severe the scoliosis, how big the scoliosis is on an X-ray. We factor in other things. What's the child's general health? Do you have a heart condition that makes anesthesia a little more risky? Is your scoliosis changing rapidly? Is it getting bigger by 10 or 20 degrees a year? Or is it staying pretty stable as you get older? And so the treatment is very variable. There's a lot of different treatment options. And we have to be able to use many different types because we have to really individualize the treatment for each child. Many children with early onset scoliosis will eventually require surgery. Not all. Some children can be cured with casting. Some children, even if you have early onset scoliosis, it doesn't necessarily mean your scoliosis is going to get bad enough to require surgery. For many children, if their scoliosis is progressively getting worse at a very young age, they do need growing rod surgery or surgical techniques that allow the spine to grow while being controlled by metal or instrumentation. So many children will eventually undergo a spinal fusion, and generally speaking, for early onset scoliosis patients, the spinal fusion would be the final surgery. But getting them to the appropriate age where that can have a good outcome is part of the key. I'd say the primary goal is to have a child grow to meet their full adult height so that their lung volumes can keep up with the rest of their body when they're an adult. Obviously, we'd like to do that in as psychologically stress-free a manner as possible, which is another reason to avoid surgery as long as we can. But we're looking at the whole child, not just the spine, not just the rib cage, but the growth of the entire child, and hoping that at the end of the day they have a chest and a spine that keeps up with the rest of them.